Good morning, everybody, to this first session. We just had a nice little chat. Bob Hasserjian just asked me, shall we start on time? I said, I'm Greek, so I think we should go 2 minutes over time and, and then see how things evolve. And he said, what, shall we cut people off when they talk too much? I say, we can't cut Arjan off. I mean, it is not possible. I mean, you know, he speaks as long as he wants. He organized the whole thing, so. Yeah, I would like to welcome you all to this morning's session, and we have a fantastic number of speakers and very knowledgeable people, and so I look very much forward to this. I don't think we need to go through all these information for you. You've already got acquainted to this meeting, to the meeting rooms, etc. We'll have a discussion after each talk for a couple of minutes and then continue. And Bob is going to introduce the first speaker.
So it's my pleasure to introduce the first speaker, a fellow hematopathologist, Sanam Loghavi from MD Anderson Cancer Center in the United States of America. And Sanam will be talking about cytology and immunohistochemistry in MDS diagnosis.
Thank you very much. Good morning, everybody. I'm very grateful to the MDS Foundation for the invitation to be here with all of you, to the meeting organizers. It's truly an honor and a pleasure. I have been charged with the task of highlighting the importance of morphology and immunohistochemistry in the diagnosis of MDS, which is not going to be entirely easy, but I'll try. So here are my conflicts of interest. All right, so I'll start with a question, and the question is there still a role for morphology in the diagnostic workup of MDS in 2025? And I think if I just had to present one slide to you, I would say yes, because looking at the diagnostic criteria by both the WHO and the ICC, you can see that essentially the cornerstone of making a diagnosis of myelodysplastic syndrome or myelodysplastic neoplasms is the presence of morphologic dysplasia, of course with the exception of a few genetically defined MDS cases that we know the ICC recognizes, but you really need to have cytopenias together with dysplasia and evidence of clonality for the most part to make a diagnosis of MDS. So yes, we do. But in practice, how do we actually apply morphologic criteria to subclassification or the diagnosis of MDS? And if you look at the current status of MDS classification, so I have both the ICC and the WHO here. Of course, we have the genetically defined categories that are the deletion 5q, SF3B1 mutated MDS, and multi-hit TP53 MDS or MDS with biallelic TP53 loss. But then if you don't qualify for any of these genetically defined categories, we revert back to our morphologic subtypes. And what are the morphologic features that we take into account to subclassify these morphologically defined cases? So one is what's recognized by the ICC still, and I think very rightfully so, is the presence of multilineage versus unilineage dysplasia. So that's important, whether or not you have multiple lines of dysplasia. Of course, blast enumeration is important in both systems, in the WHO and the ICC. Bone marrow cellularity to highlight the importance of hypocellular MDS that overlaps somewhat with the aplastic anemia spectrum is important and recognized mostly by the WHO. And then, of course, fibrosis, which we know is a poor prognostic factor. Fibrotic myelodysplastic syndrome is recognized by the WHO as an official category of MDS. All right. So, but can we go beyond this? Can we use morphologic features to decipher or to, as an underlying clue to what is actually going on genetically in the setting of MDS? And the answer is yes. I think, for an experienced hematopathologist, we can tell with fairly good reliability what the underlying genetics are going to be. This is more reproducible, I think, in AML, but you can also, apply some of these features in MDS. So what are these? I think megakaryocyte morphology for del(5q) MDS is very characteristic. Oftentimes when we see this, before we even know the genetics, we can guess that we're dealing with a del(5q) case. Of course, ring sideroblasts, as described by many of you, including Ellie, the IWG criteria, ring sideroblasts are characteristic for SF3B1 mutations. We tend to use aberrant expression of p53. Here, I'm showing you an aberrant overexpression, but of course, we recognize the null pattern as well. That correlates fairly well with the presence of TP53 mutations, and I'll go into more detail about how we use p53 IHC. Fibrosis, as we said, is a distinct category of myelodysplastic syndrome and associated with prognosis and certain genetic features. And as we said, blast enumeration is important and prognostic. And then uni versus multilineage dysplasia, and I'll show you some examples of this. So I'm going to spend some time on MDS with biallelic TP53 inactivation, or mutated TP53 as the ICC refers to it, and how we actually use the IHC, and why I feel it's very helpful to be familiar with the nuances of interpreting the IHC together with the molecular data. So here's an example of a case that has p53 mutation with a nice aberrant overexpression of p53 in the setting of a complex karyotype. So this is a perfect example, slam dunk, of TP53 with biallelic loss of TP53. So how do we actually interpret this stain? What is this aberrant overexpression? If we think about the mechanism of expression or accumulation, aberrant accumulation of p53 in the cell, in the nucleus, when you have a p53 mutation, the mutant protein is resistant to MDM2-mediated degradation. And so what happens is you get accumulation of p53, including, so the stain is agnostic of the mutation. It picks up wild type and mutant p53, but the mutant p53 is resistant to degradation, so you get this accumulation that manifests as overexpression. If you compare it with a wild type p53 on the right-hand side, you can see that there's faint patchy expression, and that is the normal level of expression. A complete absence is also abnormal and correlates usually with nonsense or early truncating frameshift mutations where the antibody doesn't recognize the epitope anymore. So, but the important thing to recognize is that only the 3+ that I'm pointing to is more specific for the presence of a mutation. And you can have 1+, 2+ overstaining in the setting of rapid proliferation, of course, because there's more p53 in the nucleus, right? So that's one caveat. The other is, through the tremendous efforts of Elsa, Ellie, and many of you in the IWG, we know from this seminal effort that the allelic status of p53 is very important in the setting of MDS. And so how do we use this in practice, clinically? One thing to highlight is that none of our clinical labs are performing single-cell sequencing. And of course, this study was not based on single-cell sequencing results. But just to highlight that when we say multi-hit TP53, it's probably more accurate than saying biallelic loss of TP53, because we're not really single-cell sequencing, and we're mostly inferring, based on the biology of disease, that when there's 2 mutations, it's probably biallelic. So there's loss of both copies. When there's 1 mutation and a deletion, again, you're probably dealing with a multi-hit. I think where we have the most problem, because many clinical laboratories are not specifically using assays that can detect copy-neutral loss of heterozygosity, is we try to use a variant allele frequency as a surrogate to say that there's copy-neutral loss of heterozygosity. Now, if you look at different literature, this number varies, and it can go from 23% up to 50%, where we say, okay, this is the VAF that we're going to use that says there's probably copy-neutral loss of heterozygosity. So we just recently did a study and looked at all of our AML and MDS cases with p53 mutations at MD Anderson, And in our hands, the number that emerged as significantly being associated with outcome, both in MDS and AML, was 40%. And I hope to highlight for you why I think still using a 40% cutoff, we're probably missing some of these cases. And to this point, there was an abstract that was presented at ASH in 2022, where through some very sophisticated statistical modeling, they actually came up with a threshold of 23% VAF, predicting a probable biallelic loss or biallelic status. And so here's an example of a case that I saw recently in practice. This bone marrow is clearly dysplastic, multilineage dysplasia. You can see on the aspirate smear that the granulocytes are fairly dysplastic. There's an erythroid cell with basophilic stippling of the cytoplasm. There is one TP53 mutation with a variant allelic frequency of 34%. So if I apply my own 40% cutoff, this really doesn't qualify as a multi-hit. Yet if I look at the optical genome mapping results, and here you can see, while the copy number is neutral, right? There's 2 copies, and here's 17. The copy number is neutral. Here you can see that there's copy neutral loss of heterozygosity clearly in the TP53 status locus. So this is, in fact, a multi-hit TP53. But I think here, again, the IHC is helpful, but it doesn't really, the IHC is agnostic of the allelic status, but it does tell you, it does quantify with some extent the burden of disease. And I think that is important. So here, again, you can see probably 40% of the cells have 3+ overexpression of P53. The other thing that we find very helpful in our practice is that in cases where you're dealing with CHIP or clonal cytopenia of uncertain significance without having other evidence of MDS yet, the pattern of P53 is usually normal. And I think this is very helpful and important. And one of the things that I want to highlight is that if we go back to the Lichelle Weeks and Ben Ebert paper, in their statistical modeling, in healthy individuals, TP53 mutations did not predict for a higher occurrence of myeloid neoplasms. And I find this very intriguing is because even though you have, this is an example where you have a P53 mutation with a VAF of more than 30%, but somehow this is being compensated and there's no accumulation of P53 here. So again, very helpful for us in making this distinction. And the last point about P53 is that if you're dealing with a suboptimal sample, which is what I'm showing you here, this is a bone marrow aspirate with essentially no spicules, we essentially just sequenced peripheral blood and got a P53 mutation with a VAF of less than 5%. So if you did not look at the morphology or the IHC, you can say, oh, this is probably CHIP, right? But then if you actually look at the morphology, you can see that the majority of the cells that are staining 3+ are the megakaryocytes that were probably never represented in this sequencing material. So again, I think an important point to make. And then finally, in that a lot of the fibrotic MDSs, so MDS with fibrosis and increased blasts, so about 50% of these cases do actually have TP53 mutations. So I think before we call anything MDS with fibrosis, it's really good to know the P53 status. And here's an example of this. Okay, so next I'm going to focus on SF3B1 and oligomonocytic CMML, and this has been a really, truly, fantastic effort by Curtis Sakowitz, Elsa, who's sitting here in the room, George, and Ellie, together with many of you. And this paper is currently under revision, so we'll see how it goes. But we tried to look at some of the differences in the classification to see if we could use this data to inform the next iteration of the classification. And two of the really important themes that emerged, one was, is SF3B1 mutated MDS really a uniform group of cases? And I'm going to try and tie this back to morphology, but bear with me for a second. So here's an example of a patient. This is a 60-year-old woman who has really mostly just macrocytic anemia, 15% ring sideroblast, no increase in blast, a diploid karyotype, SF3B1, a canonical SF3B1 mutation with a VAF of 23%. And by all means, when you use the calculator, the IPSSM calculator, this person has a low-risk disease. Okay, so here's one example. Oh, sorry, one more thing. So both by ICC and WHO, this case classifies as an SF3B1 mutated MDS because the VAF is 23%. On the other hand, here's an example of an 86-year-old man who has pancytopenia, multilineage dysplasia, 50% ring sideroblasts. And then if you look at the clonal complexity of this case, clearly very different from the first case that I showed you. And when we plug in the numbers into the IPSSM calculator, this person actually has high-risk disease. So why does this matter? We actually went back and looked at the IWG data and identified 739 cases with pathogenic or likely pathogenic SF3B1 mutations. Now here we included every mutation, not applying the 10% ICC VAF or the 5% WHO VAF. So we looked at all the cases with SF3B1 mutation, and we intentionally did not exclude RUNX1 because that was one of the disagreements between the two classifications. So the majority of these patients actually do have clonal single SF3B1 mutations, but what about those that don't? What about those that have a VAF of less than 10%, or when the mutation occurs in the context of other mutations? And if you look here, the cases with subclonal, I think this is very intuitive, but it's just nice to see this data. The cases with subclonal SF3B1 mutation were likely to co-occur with other high-risk mutations such as ASXL1 and SRSF2. And of course, when you applied the IPSSM, they were less likely to have low-risk disease if they had subclonal SF3B1 mutations. And then, of course, this correlated very well with outcome, where if you applied the 10% VAF, so SF3B1 with VAF of less than 10%, or when SF3B1 was subclonal to other mutations, these patients have shorter leukemia-free survivals. And SF3B1 clonality did remain significant in a multivariate model. So going back to both cases, I want to show you now the morphologic features of both cases that we talked about. So on the left-hand side is the patient with a single SF3B1 mutation with a VAF of more than 10%, clearly erythroid predominant marrow with erythroid dysplasia. But on the right-hand side, if you morphologically look at this, there's no way that these two cases are the same, right? There's multilineage dysplasia, there's monocytosis, there's increased blasts. So again, I think morphology can help provide some clues. And then finally, I want to speak a little bit about oligomonocytic CMML. So if you recall, both the ICC and the WHO have revised the diagnostic criteria for CMML, lowering the prerequisite absolute monocyte count to 500 instead of 1,000, while retaining the 10% relative monocytosis. And this was largely to allow us pathologists to make a diagnosis of CMML earlier when you're dealing with a clonal condition. So both systems require clonality, but they don't specify what type of clonality. So again, we used the IWG cohort, and we identified 264 cases that would qualify as oligomonocytic CMML that we're calling AMC low, and compared these with MD-type, MDS-type CMMLs with a monocyte count of more than 1,000. And if you looked at these cases, of course, the AMC high cases, the true CMMLs, were enriched for TET2, SRSF2, and RAS pathway mutations. And then the low monocyte cases, or oligomonocytic CMML, was enriched for DNMT3A and SF3B1 compared to the true CMMLs. And biallelic TET2 and TET2 SRSF2 was associated with MD CMML, of course. Again, saying, as we all know, that this is a more specific genotype for CMML. Now, if we do factor analysis of mixed data and try to, so on the right-hand side, the orange are the true CMMLs or MD CMMLs, and the purple are the oligomonocytic CMMLs. And if you cluster them based on their monocyte count and then overlay these clusters on the genetic subtypes, including biallelic TET2, SF3B1 mutation, del5q, and RAS mutated cases, you can see that the oligomonocytic CMMLs really are heterogeneous. Some of them truly do have the genetics of CMML, and others don't. They cluster with the SF3B1 cases. And so one of the things that we hope to advocate for is including CMML-type genetics in the criteria for oligomonocytic CMML. And we have validated this in the setting of sorry, I'm going over time, so but in our MD Anderson cases, essentially showing that if you cluster these cases by diagnosis and by their genetic subtypes, one of the most important things that emerges as being predictive for true CMML is bone marrow monocytosis. So again, a morphologic feature that is helpful. I'll skip through this. One last slide I want to show you is that, there are some morphologic clues to the presence of germline predisposition to myeloid neoplasia. And in my experience, whenever I see an MDS or an AML case where I think the patient may actually have myeloma because there are so many plasma cells, is when I'm dealing with a germline DDX41 mutation. So I think a helpful clue. And then finally, one last slide on what may not be MDS, but may have dysplasia, is this is a 29-year-old man with history of testicular cancer, status post-chemo, presents with very profound anemia and gets admitted to the hospital. And this is an email that I got from the clinician on the day. They were about to admit the patient, so they wanted to know if the patient had high blast or low blast and whether they could treat him inpatient or outpatient. And this is the bone marrow, clearly erythroid predominance, dysplastic, but the flow in this case was completely normal. And here, if you look at these cases, you can see very nice vacuoles, and it turns out that this patient actually had copper deficiency because he was taking 300 milligrams a day zinc to avoid COVID-19 infection. And with that, I think I rest my case, and I hope that I was able to convince you that morphologic assessment does still have value in the workup of MDS for the very reasons that we discussed, and I'll be happy to take questions if there's time.
I think we have time for one question, if there are any. I think, yeah.
Hi, very interesting. I have a question regarding the oligomonocytic with SF3B1. Did you see ring sideroblast as well in the bone marrow? And second question, sorry, is there were a difference in the hotspot variants, or is always typically K790E?
Okay, so first question, not in the IWG cases, we didn't have the ring sideroblast information, but in the MD Anderson cases, I know this, and there is ring sideroblast when you have SF3B1 mutation. And some of those are truly CMML, so it's not that SF3B1 excludes. So we actually have a blood advances paper describing oligomonocytic or CMML with SF3B1 mutation, so it does truly happen, but it's enriched in the oligomonocytic CMMLs, and I think some of those are truly MDS, not CMML. And the second question was
regarding the hotspot variants. If they differ between.
Not in the oligomonocytic CMML, but in the MDS cases, the K666 variants, which we know have worse outcomes, do occur more frequently in the setting of subclonal SF3B1.
Okay, thank you very much.
You're welcome.
I think,
Can I?
okay, one quick, if it's quick.
Sanam, you gave an excellent overview, and just I want to be slightly provocative and remind you that not everybody is Dr. Loghavi or Dr. Bennett or Dr. Rob Hasserjian and so on. And morphology in 2025 is becoming, I mean, it's an old, we know it, it's important, but it's becoming more and more difficult to many people while we have other techniques. So I would like to draw your attention, number one, think about how to gain most of the information from peripheral blood and not bone marrow. And number two, to use other clues as well, because it's becoming more and more, and we have to remember that the inter-observer variation is pretty large.
Fundamentally, I agree with your observation, but I would like to have a job, so I'm going to say that my role is probably still important, but I agree.
I think Moshe is dealing on flow. I think that he means flow is necessary.
Probably. And there is the fantastic takeover for your next talk, which is on immunophenotyping in myelodysplastic syndromes. And you know that Arjan for decades now has advocated using immunophenotyping in MDS, and well so. And we would like to know the latest advances in this field. Arjan.
Ari, thank you. Robert, thank you for being here also. But there is still a problem. Although I advocate already for a long time flow, why do you not all use flow? And that is really a problem. So I'm not really convincing you, and I do my best again. But first of all, I'm fully in agreement with Sanam that morphology is a mainstay, and it is the first option always. But we have so many cases in clinical practice on a daily basis that we do not have the clue directly under the microscope, and there comes flow. I try to convince you. I have not really interesting things of interest here for today. So I'm provocative that I always have integrated diagnostics. And it was already for a longer time that we recognized the cytopenias that's always necessary for making the diagnosis of MDS. And then we have decisive criteria as an increase in blast counts. That's also not a problem. We can count them by the morphology, but also we can enumerate them by flow. But that is not really the problem for what we use flow. So that are really criteria for already known MDS, next to ring sideroblast and the upcoming all kind of NGS issues. But already for years we recognized that as a co-criterion in which the B criteria, the decisive criteria fail in case of dysplasia, etc., that abnormal immunophenotype adds to the diagnostic workup. But at the end, it should be an integrated diagnosis. So that is the point here. So if we then look to the classifications, and I don't go to the details because the next plenary session is about these issues, we have now the morphological defined MDS subtypes as well as the molecular defined subtypes. But we don't see any issue about flow still here. In the former WHO classification, we already alluded about it, that aberrant flow blast cells could be added to the diagnosis, as well as aberrances in the maturation process could add, but in the new classification, it's a little bit diminished. So we have still work to do. And also in the harmonization program, we will discuss that in the next session, no issue about flow, all molecular defined subtypes. But why can it help us? And it was already a little bit alluded by Sanam. Dysplasia is subjective and often not specific for non-neoplastic conditions. And on the right panel, you see a lot of morphological pictures, and none of these are all dysplastic, but not MDS. So there is a lot of problems. And also in especially low-risk MDS, cytogenetic abnormalities are not so frequent. And also, mutations are not defining MDS per se. And their flow might help us, and not in increased blast counts, not in specific really cytogenetic monocyte 7 or whatever, then it might not add specifically, maybe from prognostic points, but not diagnostics. So what's actually the concept? If you look under the microscope, we start by the myeloblasts recognized by us, and then follow the differentiation pattern. It's quite clear that this can be recognized under the microscope, but if we have a cocktail of antibodies which recognize specific antigens, like CD13, it's on the most primitive cells, it's very low. And then in a normal situation, it's rapidly increased and then down-regulated upon an increase in a more mature stage. As well as for CD11b, it's not on the primitive cells. It's a little bit later, as well as CD16. But if you have a pattern which is totally disorganized, it is related with dysplasia. For instance, CD11b on the most primitive cells is aberrant, like we use that as a leukemia-associated immunophenotype in AML, as MRD, for instance, or as a leukemic stem cell marker. So these patterns are very well conserved in all non-neoplastic conditions, but in neoplastic conditions from mild origin, it is disbalanced, it's aberrant. And here you see a typical picture of the so-called Nike stripe, in which we have a maturation in this direction towards the more mature cells, and aberrances in this pattern, which can be fully automated analyzed, might be a clue for myelodysplasia. And what are the major issues which can contribute? The percentage of primitive cells, so that are not blasts, because blast is a definition of the microscope, but these are progenitor cells, and an increase already below 5%, but over 3%, is highly indicative for MDS. And it is also highly reproducible between labs, within labs, but also between labs. And an abnormal immunophenotype, like we use already as an MRD assessment, but then a diagnosis, is highly relevant in making the diagnosis, as well as leukemic stem cells. But also the maturation patterns, both on the granulocytic level, monocytes, as well as erythroid cells, show specific patterns in normal situations and aberrant in dysplasia. And finally, the monocyte partitions, that means the differences between monocytes reactive or in the context of CML, might contribute. I will have a slide later on. So to look into depth into these cell compartments, we have made recommendations. And this, don't read it in detail, but what is said here, these panels, some as backbone, the myeloid progenitor cell compartment, within that compartment, the lymphoid progenitors, within the CD34 positive cells, and there the granulocytes and monocytes, as well as erythrocytes, and in addition, some other cells. But these are the main cell compartments with this panel, which can easily detect disbalance in maturation or aberrances on the progenitor cell level. But you see 44 parameters for this analysis. Not easy, but we try to make it easy to transform this in a scheme in which we can enumerate the aberrances based on this analysis. And I do not go into too much detail now, but the former well-known OGATA score for most of you has 4 parameters, including several on the progenitor cell level, as well as the scatter that is related to the hypogranularity by the microscope in granulocytes, and others are depicted over here. No or over 2 aberrances in the 4-parameter analysis. But in addition, you can zoom in with that antibody panel to dysplasia on the progenitor level, on the more maturing cells, both neutrophils and monocytes, as well as in the erythroid lineage, and then come to A, B, or C. That means C, fully consistent with MDS features, or A, no results indicative for MDS, based on pattern recognition, based on automation of changes in immune fluorescence expression of a specific antigen, etc. So this seems to be complex, but in general practice it works very well. But to make it less complex, we try to make a fully computational analysis, AI-driven, to look whether or not we can dissect from the 44 parameters quite easy in 30 seconds the diagnosis. And what you see here, that we here have the so-called 4-parameter score with a relatively low sensitivity and a specificity of almost 90%. With the 44-panel integrated flow score, we have a higher sensitivity, mainly in low-risk MDS, because high-risk MDS is mostly not a problem with this specificity. But going to a fully automated single-tube analysis, quite easy. We have both in the validation and in the validation cohort, we've shown up to a 97% sensitivity and specificity with the 44-parameter analysis in 30 seconds to have that as compared to the manual technology. So it adds already to the diagnostic workup. But still, 44 parameters. That seems to be a little bit complex. But to dissect also from this computational analysis specific features based on data-driven analysis, we also experienced that by doing this kind of flow sum analysis, in this flow sum we have clusters of erythroid cells. We can easily transfer that to a so-called two-dimensional plot, and here we recognize the progenitor erythroid blood cells. And what is interesting from this point, that we envision that within those erythroid primitive cells, the scatter is a specific feature within the early progenitor cells of the red blood cells is highly relevant in this computational analysis. So by doing this kind of analysis, we see new features which were not highlighted before, were indicative for MDS in lower risk MDS specifically. But then we asked question 44 parameters, can we reduce the amount of antibodies and analysis? And what we did within the European Leukemia Net working group on flow in MDS, we tried to have in multicenter the question, which are actually the most important features to encounter? And we came up with 17 parameters depicted. depicted over here. Don't read it in detail, but here you see only one on the erythroid lineage, some on monocytes, some on neutrophils, and some on the myeloid progenitor cells. And this 17-parameter cocktail identify MDS as well as compared to the integrated flow score with the 44, quite secure, with a high accuracy, MDS or not. In combination with, for instance, an increase in progenitor cell counts over 3%. And all of these patients were already MDS. And they do not speak about 20% of blasts. That's not relevant for the diagnosis, but already an increase over 3% of progenitor cells, maybe in the context of aberrancies, is highly indicative for a myeloid disease. So to validate this, we have in an independent cohort, it is just published, we could show indeed the same results of the multi-center cohort in a single validation cohort, that indeed, as compared to the integrated flow score, especially in low-risk MDS, that is clinical practice, we have an accuracy of very high in the integrated flow score, but to lower the amount of antibodies, to make it simpler for clinical practice, we have a similar accuracy up to 80%, 86% of specificity and sensitivity for the analysis of cytopenic patients. So I hope I convince you that this all helps you in the diagnosis of MDS. An example, a young woman came to the clinics with cytopenia, and by the microscope there were no increase in blast counts, nor in the peripheral blood, nor in the bone marrow compartment, no dysplasia, but she was cytopenic. But by zooming in on the progenitor cell counts, they were very, very low, you could easily identify that within the primitive compartment, CD34, and in purple you see the expression of the specific patient, and in the dashed line, normal expression, and this is to control the lymphocytes. You see that this is the CD34 expression, quite normal, a little bit lower than controls, but then CD7, it is never expressed on primitive progenitor cells of the myeloid lineage. But in this case, we have quite similar expression of CD7, which is a lymphoid marker, as related to the lymphocytes as a control. We see a high expression of CD7 on CD34 progenitor cells. So that is highly aberrant. As well as we see aberrancies in the level of CD33 that is high expressed as to controls. So aberrant. As well as CD11b, which is normally not expressed on progenitor cells, but in this case it is expressed. And actually this methodology was used in clinical practice already for MRD detection post-AML induction therapy. And it's the same issue in this case. And this patient had really aberrant progenitor cells and rapidly progressed in 3 months to an acute myeloid leukemia, which was not indicative by both cytogenetics. We had no metaphase growth. Later on, they came NGS parameters, okay, but low blast count. So it's quite interesting to show you this case. So this part is about CMML, and this is already the immunoflow technology implemented in the WHO as well as in ICC. And it was based on work mainly by the French group in the early days, that we separate in normal monocyte maturation and differentiation 3 monocyte subsets. There are a lot of more, but in this case these are important. The so-called classical monocytes, the intermediate monocytes, and the non-classical monocytes based on the expression of CD16 and CD14. And if you look to these subsets under the microscope, they are all the same. But by flow, they are different. And what was interesting in the observations is that in cases for real CML, in contrast to reactive conditions or other controls, the increase in the proportion of classical monocytes is always of mostly over the 94%. And these cases were really interesting to make the diagnosis of CML. And mainly in those patients which are not clonal or do not really have that phenotype of not really have the CML diagnosis by the morphologist, this could help you in making a diagnosis. Only one restriction, that if you have an inflammatory condition in CML, which is in part the case, there's a shift in those monocyte petition towards lower classical monocytes, and an increase in the non-classicals, but also other markers, as SLAN, we don't go into details, might help you then in differentiating from reactive conditions as well as from neoplastic monocytosis. So this is an example. By combining this kind of parameters, you will see here, again, a multi-parameter analysis, not only on monocytes, but also on the progenitor cells. And you see here that looking to the progenitor cells, there are some differences in the so-called coefficient of variation of the CD117. It's very small. This is the normal line. This is, in this case, so aberrant. There's a small proportion of CD7 positive blue cells, that means progenitor cells, that is aberrant. But then also there is an expression of CD14, which is a monocytic marker, on granulocytes. And that is aberrant in this case. The purple cells are granulocytes. But here you see the monocytes. There is a very low expression of CD13 as related to the control in dashed lines. It's aberrant. There's an expression of 456 aberrant, although the monocyte petition pattern is on the border of what we call the cutoff of 94%. But in this case, it's typically MDS or CML phenotype aberrancies. So this helps you in the discrimination between reactive and non-reactive conditions. So, and therefore also, it's already in this WHO classification, the abnormal petition of peripheral blood monocyte subsets, in the case when we had some problems with the definitions. But note, if the monocyte count is below the 0.5, the 500 cutoff level, this does not add yet, because clonal markers are still needed to make the diagnosis of CML. And we are currently very busy within the community whether or not the monocyte petition can also add in the so-called lower monocyte subsets to make it more discriminative, we hope. We don't have the data yet. So then we came up with this slide in which we can have an algorithm. So the mainstay, and I fully agree with Sanam and other pathologists in the room, that we have a cytopenia, we start with the microscope, because we can easily rule out other issues already. And we should rule out the vitamin B12 deficiency and other issues. And also, by flow, at the same time, we could exclude already hairy cell leukemia if the microscope cannot help us. So flow is from the beginning important. But then, if we have signs of cytopenia, not excluding all more frequent causes, then we go rapidly to a more wider application. Then the flow comes in with a 44 of a 17 parameter analysis, whether or not automatic analysis or not, as well as subsequently the additional next generation sequencing and cytogenetics for an integrated diagnostic report. And I was happy to see last blood issue by Luca Malcofati, who showed already in the context of clonal hematopoiesis a quite similar diagram. So starting to rule out a lot of other issues in cytopenia, always start. Then the microscope, and then non-clonal cytopenias based on GS. Okay, other issues. If we have clonal cytopenia, we go further with the analysis. But then also immunophenotyping is mentioned to rule out other causes of the disease, as well as the contribution of flow cytometry in MDS. It was not depicted in the discussion, but I think it is highlighting the superior role also in the diagnostic workup. But then specific other features. I think I'm a little bit over time, so I will hurry up. If we looked in detail to the SFDB1, and we could also identify within the SFD mutants a specific immune feature. If you look to the SFDB1 and we focus only on the erythroid progenitor cells, we see an increase in the frequency of erythroid nucleated cells in the bone marrow compartment, and very low in del5Q. But see, when we have both del5Q and SFDB1, which is commonly associated, we see that the immune phenotypic picture is resembling del5Q only. That means also for other erythroid markers, like the coefficient of variation of the transferrin receptor, low in del5Q on primitive erythroid cells, as well in the context of both SFDB1 and del5Q, and also others. And this questions, how should we treat then SFDB1 del5Q patients? And from this picture, it is argued that maybe those patients should be upfront treated by len instead of luspatercept. And we are very happy with other papers supporting recently that that phenotype is quite specific for this combination or for the entities by itself. And also recently it was memorized that in these cases, luspatercept is not helping in the combination of SL3B5 with del5Q, and the argumentation is in the immunophenotype. You should maybe start with LEN first in these cases. So finally, also this tool can be used for prediction of response to lenalidomide, not in a del5Q case, but in non-del5Q patients. And we showed earlier that indeed immunophenotyping with that panel can easily discriminate those patients who do good or not in response of lenalidomide in a non-del5Q cases. Too much detail for now, but this tool can be applied from a diagnostic as well as a and a predictive next to next generation sequencing indeed. So I will skip the final slides on prognostication issues, but come up to then the conclusions. I advocate always integrated diagnostics in MDS. And I hope that I will be part of Robert, we discussed it yesterday, for the next edition of the WHA or harmonization protocols to really discuss the contribution of flow as in 2025. We are working on harmonization protocols. We are still working on spectral flow technologies to make it even more practical in daily practice with a selected amount of parameters. We try to implement computational analysis, and Moshe alluded already about, we are very work hard on the peripheral blood cell tube. There are already publications on that to make it easily for a screening tool. Last but not least, there are a lot of issues regarding prognostic model, and there will soon be a paper out in which we showed that it is additional to the IPSS molecular, the flow aberrancies, and so on, other issues regarding prediction for response. By summarizing this, I would like to thank a lot of co-authors and co-investigators, not only from my lab on the right, but also in the consortium of the Leukemia Net, not only in Europe, but also across borders. Thank you.
Thank you, Arjan, and I think you really underlined the importance of flow cytometry in myelodysplastic syndromes. Now, we are a little bit over time, but you are the local organizer of the thing, and you have all the right to still get a question. Are there questions? I would have one, and that is applied to the way that we get the bone marrow. I mean, we usually do integrated myelodysplastic syndrome diagnostics, so we take a cytology and then we take the blood for the immunophenotyping. Now, the immunophenotyping guys say, no, wrong way around. You should first aspirate for the immunophenotyping and then do the bone marrow morphology, etc. Can you just say a word on that?
I have no problems with that, because it is not only the enumeration of blasts, so still we use the microscope for that. So, but the problem is, are those myeloblasts, whether or not they are 3 or 1%, doesn't matter. Flow can identify thousands of cells rapidly and look to the aberrancies. And whether or not it's a little bit more contaminated with peripheral blood or not, does not matter. Okay. Only if you use one of the criteria of blast increase, then you should be careful, think, should it be diluted or not.
Fantastic. Thank you.
Thank you.
I'm now very pleased to introduce the next speaker, Elsa Bernard. We've heard many of her publications already cited multiple times at this meeting, and we're excited to hear from her about the most recent contribution on the molecular taxonomy of MDS. Thank you.
Thank you very much. It's a great honor to participate in this session and discuss today some concepts around the molecular taxonomy of MDS. So I'd like to start by discussing 2 cases and how they classify a diagnosis. So this is a 69-year-old male with anemia, severe neutropenia, and normal karyotype, and a 68-year-old female with anemia, also normal karyotype. And molecular findings from MDS from these 2 cases for the gentleman showed 2 truncated mutations in STAT2 with a high VAF, which do suggest biallelic targeting of the genes, as well as the most common SXL1 truncated mutations, and a high VAF that there are 2 truncated mutations in a male, which is on the chromosome X. For the lady, we observe the hotspot DNMT3 mutations and the hotspot IDH2 mutations. Classifications for those 2 patients used IPSSM, were equal for IPSSM with a moderate low risk, and the WHO classification were also equivalent with MDS with excess blast 1. And I think this illustrates that for 2 cases with very different clinical presentation, and especially molecular presentation, our current tool does not capture molecular etiologies of the disease. But does this matter? This is a difficult question yet. I would like to highlight this article, which is in a very different field from a metastatic solid cancer, but where the authors argue that, interestingly, the historical classification of cancer through mainly based on histology has been a limiting rate for access to novel drugs for patients. And I think in the myeloid field, we are part of this broader concept and broader discussion, a little bit ahead of the thought process to delineate the place of morphological abnormalities in classification. So I also like to highlight that the 2 concepts of risk stratification and diagnostic classification are different. And classification, risk stratification, the purpose is to predict outcome and solely guide risk adaptive therapies. Classification, on the other hand, not only guide diagnostic, but in the long term should inform, hopefully, therapeutic development in a more targeted way. So currently, diseases in MDS only consider genetic abnormalities for a limited number of cases, where only 20 to 30% of patients are classified according to their gene mutations, and this is or copy number alterations, and this is MDS5Q, MDS SF1, and MDS multi-hit TP53. And really, this is a genetic heterogeneity of MDS that has challenged in the past years the robust delineation of genetic subtypes of clinical relevance, where we know that 94% of patients with MDS, more than 90% of patients with MDS, have recurrent driver somatic mutations, but more than 50 genes are currently observed in those patients. In average, 1 patient will have 3 to 4 driver mutations. So it is a challenge to delineate robust genetic subtypes. Beautiful work from prior groups have done this exercise and show that it is indeed possible to classify patients into distinct genetic subtypes with associations with clinical outcomes. Yet there has not been a consensus on how to define clearly these subtypes. So this is one of the questions that we asked together with the international working group, where can we use the gene-gene interaction observed in the molecular profiles of patients with MDS, as well as gene copy number strong interactions, to define genetic subtype that would account for the majority of patients and define their clinical correlates with regards to clinical presentation and outcomes. So to try and answer this question, the IWG defined a framework to study genetic subtypes in MDS. They studied 3,200 treatment-naive patients, mainly from purely MDS diagnosis, but also a subset of the cohort had a non-proliferative CMML or MDS in the MDS MPN subset, as well as AML with low blast. The cohort was analyzed by a large panel of more than 150 genes for somatic mutations, copy number alterations, and congenital LOH. And molecular classification was delineated using only molecular features, gene mutations, as I said, and allelic imbalances, distinguishing allelic states for TP53, TET2, and different hotspots in some of the genes, such as U2F1 and IDH2. Unsupervised clustering was conducted to maximize within-group similarity and between-group dissimilarity to define the hierarchical rule, which we call molecular taxonomy, which I will briefly describe. But importantly, this exercise, which was agnostic to prior work, did find again genetic subtypes that have been previously described in the literatures. This included 36% of patients that were classified into already established group, or 20% of patients into group genetic subtypes that have been previously described. as well as 8 novel groups that accounted for 30% of patients. So this molecular taxonomy can be organized into a hierarchical classification tree, resulting in 18 groups. It is based on the definition of 21 of the presence of mutations in 21 genes, 6 cytogenetic events, and LOH at TP53 or T2 locus, classifying 86% of patients into 16 molecular groups and 2 groups from negative findings, absence of recurrent disease, molecular patterns, or no drivers. So briefly, the first 6 groups are based on single biomarkers. This includes the DX41, enriched for germline mutations, AML-like group, which was enriched for NPM1, but also other events such as, for example, MLL-PTD, that Dr. Coleman-Lindsay beautifully described yesterday, the TP53 complex subtype, derivative 1,7 subtype, which is enriched for the for Asian population, subtypes with monosomy 7 or ZBP1 mutations that was characterized also by a younger age compared to other subtypes, and the rare presence of germline GATA2 mutations, and the del5q molecular subtypes characterized by the presence of isolated del5q as per cytogenetic definition. The next 4 groups was bear more complexity in the genomes, with a lot of somatic mutations observed in the same patients. This included EZH2SXL1, which was the most complex of all groups, where patients have at least 5 mutations in their driver mutations. IDH-STAC2 molecular subtype, which very much resemble AML-like on the continuum from secondary AML, BCOR-like subtypes, which had a similarity with somewhat aplastic anemia molecular features, and the B-allelic T2 molecular subtypes, which was very prevalent. It accounted for 13% of patients in this cohort, and this resembled a CMML-like molecular subgroup and subtype, and I very much agree with Sanam when she discussed how probably molecular features of CMML should be included in the continuum of FDS to MDS and PN. The residual 5 groups were defined by the residual presence of splicing factor mutations, which are mutually exclusive. And last, we had the CCUS-like subtypes, which was characterized by indolent disease, as well as negative finding, which were called molecular not otherwise specified, and no event for the absence of molecular drivers using the panel that we've been deploying. So those genetic subtypes have distinct association with clinical presentation and outcomes. Again, we recapitulated previous known associations, such as the association between 5q and NSF3 with anemia, B-allelic 2 with monocytosis, as we discussed, DDX41 in neutropenia, TP53 complex and thrombocytopenia, but also describe novel associations, such as indolent phenotype for the residual ZRCL2 group, or association between BCOR-like and thrombocytopenia. There was a large variability of bone marrow blast across the different subtypes, from median blast less than 2% versus close to 10% for the AML-like subtype as expected, as well as huge variability in terms of patient outcomes, both for overall survival and AML transformation, where the longest survival was observed for patients without observed driver genetic events, and then SF3B1, that there's 2 molecular not otherwise specified. Conversely, the rate of AML transformation was very high for some very specific subtypes, as expected, the DDX41, but also the IDH-STAC2 subtypes, which is, again, resemble AML-like subtype. But this taxonomy also provided a framework to dig deeper into some of those groups, and I will just briefly highlight how it allowed us to try to understand a little bit better those MDS without identifying molecular drivers. And this is data that Maria Sirenko presented yesterday, where in that very specific population we're using conventional panel sequencing, we did not identify any molecular drivers. We observed that in the male subset of those patients without drivers, UBA1 mutations were very frequent, accounting for 7% of these patient populations. And among those, more than 90% through retrospective review had inflammatory clinical presentations, and this is yet to be validated in prospective study. And among these patients, among the UBA1 mutation that we observed, it was mainly the M41 hotspot, as well as other drivers that have been defined, but also a number of variants of unknown significance. And one of these variants of insignificant was observed in a woman that were diagnosed very early with severe inflammatory rheumatic disease at 25 years old, and she transformed to, she was diagnosed then with MDS at 41 years old with mutation in with a high VAF TP53 mutations and a high VAF TBA1 mutation. We could delineate a little bit the molecular trajectory and clinical trajectory for this patient, and this work was led by Maria Crino together with Maria Silenko and Pedro Moja from Karolinska Institute, where they demonstrated that this woman had a somatic amplification through chromosome X trisomy somatically of the UB1 mutation. And the UB1 mutation was a germline variant that could confirm through the sequencing of the T cell subset as well as culture-derived fibroblast. These patients had relapsed both IRD and MDS and did not respond to treatment. And we also observed that not only vacuoles in hematopoietic cells, but also her fibroblasts were highly vacuolized, suggesting that this UB1 variant may affect also non-hematopoietic tissue. So because I'm in a session with Sanam, I thought I would also try to put a little bit of pictures. I still have a lot of work to catch up with her beautiful pictures, but I think the other advantage of the molecular taxonomy was to try to better understand the relationship between a genetic definition of disease and blast percentages observed in the blood or the marrow. So, and really try to advance our thoughts about should we be using novel paradigms in which genetic subtypes represent the overarching basis of classification. So first of all, it was important to highlight that across the different established blast strata of 0 to 5, 5 to 10, 10 to 19, there was a high number of molecular subgroups that were recurrent in these different strata. So there is high heterogeneity between the representation of genetic subtypes and the blast categories, and both are predicted independently for outcomes. Interestingly, in specific genetic subtypes, the percentage of bone marrow blasts did not impact patient outcomes for AML transformation, for example, in the case of DDX41 and AML-like subtypes, but also for overall survival in specific genetic subtypes of EZH2SXL1 or -7ZBP1, for example, where the majority of patients had blasts below 5%, yet they had uniformly poor outcomes with a median of survival less than 2 years across the distinct blast strata of blast, suggesting that, at least in specific genetic context, the level of blast percentages may not be important for patient outcomes. And in this context, I think I would like to use the example of MDS del5Q to really try to understand a novel paradigm for genetic classification, where really the classification should represent a biological entity, and maybe the blast will represent the stage of the disease. So in this study led by Marco Rocado, which is currently under review, they analyzed 191 patients with isolated del5Q as per cytogenetic definition. And in that subset of patients, most patients had low blast disease. It was 80% of patients, and 10% had high blast disease. And as expected, the level of blast in the del5Q as per molecular definition clearly separated outcomes. And one may argue that the low blast category represents the chronic phase of the disease, while the high blast category represents a more advanced phase of the disease. And in these molecular subtypes defined by the presence of isolated del5Q, there is still genetic heterogeneity, where the most common mutation is SRSF1 mutations, and Arjan just beautifully discussed the immunophenotype of del5Q plus or minus SF1, which represent 25% with del5Q, as well as high prevalence of other genetic mutations, DMT2, monoallelic TP53, ISXL1, and kinase 1A. And in that specific subtypes, this has been described in several studies and validated again in that study. The presence of SF mutations for patients with isolated del5Q is an indicator of worse outcomes, which is very different from the MDS SF1 well-identified subset. So taken together, all this piece of data, including the fact that there is representation of different blast percentages within the del(5q) category, as well as remembering the landmark data from lenalidomide treatment that did say that high blast patients with del(5q) do respond to lenalidomide. Taking into account the different co-mutations, the authors suggest a framework where the patients with del(5q) are categorized together and using blast count as an indicator of the stage of the disease, as well as other molecular qualifiers, such as presence of SF sub-1 mutations, monoallelic TP53 mutations, which is very important to monitor disease, especially under lenalidomide treatment, as well as other mutations. Last, I think the molecular taxonomy is also provide also useful framework to study genetic heterogeneity across different disease boundaries, such as MDS versus MDS-MPN, which I'm not going to go into, or across different disease subsets, for example, therapy-related MDS. So this subset of patients with therapy-related MDS are associated with high-risk disease features. This is very well recognized. There is a high prevalence of TP53 mutations in more than 40% of patients, as well as PPM1D mutations in about 10% of patients, which is a different representation compared to primary MDS. And they're also associated, compared to primary MDS, with poor prognosis. When we apply the molecular taxonomy to more than 200 patients with TMDS, we observe the expected enrichment for the TP53 complex molecular subtypes, as well as the monosomy 7 ZBP1 subtypes. But really, there is still high heterogeneity, where 7 molecular subtypes were observed in more than 5% of patients with therapy-related MDS. And once we account for the genetic basis of the disease, we did not observe strong differences in terms of patient outcomes. However, this was a rather small cohort with no annotation in terms of clinical parameters from the prior history of the cancer, the remission status of the prior cancer, and this is studies we're going to pursue within the IWG in the next years. And also, notably, for example, PPM1D is not discussed in the molecular taxonomy yet. And really the role of PPM1D mutation in the context of patients exposed to previous chemotherapy or radiotherapy is not well understood yet. And we recently analyzed 116 patients with PPM1D mutation in the spectrum of myeloid disorders ranging from CS to CCUS to MDS and AML. And observed co-mutations with a number of genes, including TP53, but still more than half of patients did not have TP53 mutations. And in some cases, for example, here it's a case of a patient with osteosarcoma that have stable PPM1D mutations that 45 months after treatment, the PPM1D mutation expand, and we could confirm by single-cell sequencing that it was in the founding clone and transformed to AML with complex karyotype with wild-type TP53 in that case. We also tracked PPM1D mutations in patients treated for ovarian cancer across several time points. And interestingly, while in some patients the clones are stable or progress, in 4 out of 10 patients, after the termination of treatment, the clone of the PPM1D mutant could regress. And I think we are yet to understand the dynamic of those clones under selective pressures such as treatment, and understanding the regression of those clones might allow us to leverage later on some therapeutic vulnerabilities. So with that, I very much would like to thank you for this beautiful time in Rotterdam. I think I'm looking forward to seeing tulips that have many looks and then be classified in different colors. And as per the genetic subtypes, we have a lot of work to do, characterizing symptomics, epigenetics, and immune profile. Thank you very much.
Thank you very much, Elsa, for that excellent talk. We are running a little bit. Maybe it's better if the questions you take during the break, if that's okay.
Yeah, that's great.
We should probably move on to the next presentation, but thank you very much.
Thanks very much. And we are now going into optical genome mapping, and Aline Aywaz will present on her work. Thank you.
Good morning, everybody. It's a very pleasure and honor to be here today. First, I would like to thank the organizing committee for selecting my abstract for oral presentation. So, my oral presentation topic is the practical application of the optical genome mapping methodology as a diagnostic tool in myelodysplastic syndrome. Before starting to discuss about the application of optical genome mapping, it is essential to briefly review the diagnostic approach of MDS. Based on European Leukemia Net recommendations, the diagnostic approach for MDS should include the morphological assessment for blood and bone marrow, cytogenetic analysis, FISH, flow cytometry, and molecular genetic tests. The cytogenetic abnormality is very important, as we know, about the prognosis and treatment guidance. But conventional cytogenetic analysis has its limitations, like low resolution. It detects only large chromosomal aberrations. It requires dividing cells, labor-intensive and time-consuming. It misses cryptic aberrations. It cannot detect the subtle structure variants, like small insertions, deletions, or translocations. So that was the reason that optical genome mapping enters the picture, so as a high resolution and culture-free method and a genome-wide method. So optical genome mapping is a technique used to visualize the structure of the genome at a high resolution. It allows the detection of genomic structural variation with a resolution of 500 base pair with more than 99% accuracy, and also allows the detection of up to 5% mosaic clones with 99% accuracy. So the aim of the study, or my small project, was to evaluate the application of optical genome mapping for the cytogenetic characterization of MDS and to determine whether this technique could complement or replace the karyotype. So 20 patients with MDS at Hematology Department of University Hospital Leuven in Belgium were selected and collected between 2021 and 2024. Karyotyping was performed to all the cases, all the patients. High molecular weight DNA isolated and labeled. And the labeled high molecular DNA molecules are linearized by Saphir BioNano optical genome mapping system and software. We use the rare variant pipelines to analyze the molecules. So we consider the copy number aberration more than 10 MB in OGM, as this is generally considered the resolution of conventional cytogenetic analysis. The OGM results were considered concordant with the karyotype if the same CNAs and SVs were detected by both techniques. Results were considered discordant when the abnormalities identified only by one method. So 3 cases were with normal karyotype, 1 case the karyotype was failure, 16 cases with clonal abnormality. The most clonal abnormalities were monosomy 7 and deletion 5q. By OGM, 3 cases have a normal result, 9 cases with complex aberration, 3 or more abnormalities, 8 cases with single or double aberrations. So the normal results were identified in 3 cases by both karyotype and OGM. 9 discordant cases show difference in the result obtained by OGM and karyotype. 7 concordant cases, as you see in the table, those 7 cases, the results were the same comparing with the karyotype and OGM. Here, in this case, you can see the karyotype is failed, but we got a complex OGM result with many CNAs and SVs. So you can see here that there is a cryptic translocation between chromosome 3 and 7 involving MECOM and GRM8. So in the circus plot, you can see the complex finding by OGM, and here in the genome browser you can see the translocation between 3 and 7 that involving MECOM. I want to present some discordant cases. First case, we find independent clone with deletion 9q21q31 by karyotype. OGM failed to detect this abnormal clone. Why? Because the fact that OGM technology has a detection limit. The VAF of about is 5% for SVs and 10% for CMVs and aneuploidies. So the abnormal clones with VAF lower than 5% can be missed using OGM. The second discordant case, there was a derivative between chromosome 1 and 15, involves the whole long arm of chromosome 1 and 15. The breakpoints were in the centromeres. We reported this case by karyotype, but wasn't detected by OGM, because OGM has its limitation also to detect the SVs in centromeric region or in repetitive sequence regions. So by OGM is not able to detect Robertsonian translocation and the centric fusions. The third case, you can see here complex karyotype as well as complex abnormalities obtained by optical genome mapping. If we compare the findings in this table, you can see that there are many copy number aberrations and structural variants that cannot be detected by karyotype or not seen by karyotype, as well as you can see that by OGM, we detect the deletion of TP53. So OGM is a valuable tool not only to detect the SVs, as well as to obtain of high resolution breakpoints. OGM allowed the determination of whether genes or regulatory elements are affected and whether complex rearrangements are present. So the concordance in comparison to karyotype reached 55% because OGM cannot be properly analyze some critical regions like centromeres. The advantage of OGM comparing with the conventional cytogenetic analysis, SV detection, by providing detailed genetic information on a genome-wide level that improve the clinical diagnosis, prognosis, and therapeutic decision-making that might improve the outcome of MDS patient. The diagnostic should be performed on all samples without loss in quality because like 10 to 15% of karyotype bone marrow can be failed. So this increased the diagnostic yield. OGM can detect high resolution breakpoints that allow the determination of whether genes or regulatory elements are affected. So to take home, OGM can discover novel and potential clinical significance SVs and CMVs. It is usual method in the diagnosis and risk assessment of MDS. OGM can be adapted instead of FISH and microarray for sure, but in addition to karyotype. Larger clinical studies are needed to determine if OGM can be replaced karyotype or not. I'm not sure, but ALN recognized that its potential, but requires more clinical validation. For now, it's not officially recommended, but can be used with other methods. I would like to thank the Center of Medical Genetics of Armenia, Faculty of Medicine Montpellier in France, and Leuven Hematology Department in Hospital and University of Leuven that give me the opportunity to make this small project in the Hospital of Leuven. Thank you.
Thanks very much. Very interesting. Are there questions? Yes, go ahead.
Thank you. I was intrigued by your, you had a failed karyotype for this one case with the MECOM translocation, and yet you said that it was a cryptic aberration.
Yeah.
But the breakpoints were such that it would have been visible if you would have had a karyotype. Why do you call it cryptic?
Yeah, you are true that if we had the karyotype, we will, and the resolution of the karyotype, the quality of the chromosomes, maybe we will be okay, good. So it can be seen by karyotype too. Yeah.
Go ahead.
Hi, Ekaterina Balen from Germany. Thank you for a wonderful talk. I have always the concerns about the availability of the methods, because it's everything perfect and you've done this job in Leuven, but you're coming from Armenia. So my question is it available? Yeah. Do you have this equipment there? Is it possible to somehow make it possible for the patients there?
Yeah, very good question. In Armenia, the genetic tests are not covered by the government, no insurance. So we have a contract with Institute of Pathology and Genetics in Belgium. So the patient that want to send a sample, we collect the sample and ship to Belgium. They do the wet lab and send the data to us, and we do the data analysis. Till now, we work in that way, but we are planning to get the system, optical genome mapping, next year. So we have a contract with, we work together with Hematology Center of Armenia. So we will do some project, mutual project, to get the system in Armenia. Thank you. Thank you.
And now we move to the last presentation of this session by Julia Mestre from Spain, who will be talking also about another application of optical genomic mapping, genome mapping.
Hello. First of all, I would like to thank the scientific committee for giving me the opportunity to present today the results of our study, which is focused on the application of optical genome mapping in assessing the genomic complexity in patients with therapy-related myeloid neoplasms and myelodysplastic syndromes younger than 50 years old. It's not working. Okay, so cytogenetic studies in MDS play a major role in confirming diagnosis, in the prognostic risk stratification, and in the therapeutic decision-making. It's estimated that around 50% of MDS present with cytogenetic alterations at diagnosis, and in contrast, chromosomal alterations are found in more than 90% of therapy-related myeloid neoplasms, that are those myeloid neoplasms appearing as a late complication of the cytotoxic therapy received during the treatment of a previous malignant or non-malignant disease. TRMN have a especially complex karyotype and a worse prognosis. So cytogenetic alterations are detected by chromosome binding analysis, which is the gold standard technique for the assessment of structural variants, and is a critical component of the revised international prognostic scoring system. This is the prognostic algorithm most commonly applied for MDS and therapy MDS. Even so, a significant number of patients do not exhibit detectable cytogenetic alterations, while in some other cases, CBA might not provide an informative result. And this could be mainly explained by the fact that CBA resolution is limited. Also, it depends on the binding cells, and it's not able to detect cryptic or complex structural variants, all of this contributing to underestimation of clinically relevant abnormalities and a compromised accuracy in risk assessment. Given this context, the emerging technology of optical genome mapping presents as a promising alternative, since it offers a genome-wide view of structural variants, it has a higher resolution, and it allows the detection of both balanced and unbalanced alteration. So, with this, the aim of this study is to evaluate OGM applicability to elucidate the presence of alterations that remain cryptic under karyotype resolution, and to define OGM potential in enhancing the prognostic stratification and classification of patients. To do so, we selected 34 TRMN patients and 28 MDS patients younger than 50 years old with available cryopreserved bone marrow cells, and we did the isolation of ultra-high molecular weight DNA. After that, we labeled this DNA and we loaded it into a chip for its imaging using the Sapphire scanner. Finally, the genome analysis and visualization was performed using the rare variant analysis and the de novo assembly pipelines. About OGM settings, we used the reference genome, the 38 version of the reference genome, achieving an average map rate of 88% and an average effective coverage above 400. And just to highlight that we use 2 bed files in order to be able to detect candidate alterations. So if we focus first on the TRMN core, the application of optical genome mapping allowed the detection of chromosomal alterations in 80% of patients compared to the 41% according to CVA and a 6% of patients where CVA couldn't be performed. If we focus now on the young MDS cohort, CVA detected alterations in 40% of patients, with a 10% of patients where CVA was not informative, and after the application of OGM, the percentage of patients with alterations rose above 50%. Given these results, we decided to evaluate OGM performance in each karyotype context. So if we focus first in those patients who had a normal karyotype but alterations by OGM, we found that 40% of young MDS patients had alterations bigger than 5 megabases, compared to 10% of TRMN patients, and the most relevant alterations was a loss of a 5q arm that allowed the reclassification of this patient from the MDS low blast to the MDS deletion of 5q category, and a loss of the 20q arm in one young MDS patient. Nevertheless, none of these alterations had an impact in the IPSS-R cytogenetic risk score, since these 2 deletions still belong to the good category. Regarding the regions of homozygosity, they were more frequent in the young MDS cohort, and they were mainly present in chromosomes 2 and 7 in the TRMN cohort, and in chromosomes 12 and 16 in the young MDS cohort. All of these regions were overlapping with important MDS-related genes. Regarding the alterations smaller than 5 megabases but affecting MDS-related genes, they were present in both cohorts, and we found that 85% of them were deletions, all found in the TRMN cohort, and to highlight 2 deletions affecting COOX1 gene and other single deletions affecting PTPRT, ALAS1, or RCOR1 gene. The remaining percentage were insertions to highlight this insertion in RBBP6 gene that has been described in familiar and young MDS patients. Here you have an example of the 2 recurrent deletions affecting COOX1 gene and how they were seen using the Genome browser view of the Access platform. Finally, we also searched for alterations smaller than 5 megabases affecting other carcinoid-related genes, and they were only found in the TRMN cohort. They were all deletions, and one of them was affecting the gene NAALADL2 that has been linked to head and neck carcinoma, and that was found in a TRMN patient who developed an oropharyngeal squamous cell carcinoma as a primary tumor. This is the only case where a clear correlation between OGM finding and the primary tumor type was observed. If we focus now in those patients who had an already altered karyotype, the application of OGM allowed to detect alterations bigger than 5 megabases or large rearrangement in all of the patients. So OGM allowed the validation of karyotype results. In addition, the application of OGM also allowed the detection of additional alterations, since in 17% of patients who had an already altered karyotype, we found new alterations by OGM. Nevertheless, the majority of them didn't have an impact in terms of complexity, since they were smaller than 5 megabases, and others were found in patients that already have a complex karyotype, so they were just adding more complexity to already complex karyotypes. Just in one case, in one TRMN patient, the application of OGM allowed a switch from an altered karyotype with 2 alterations to a complex karyotype, as you can see, with this translocation and several gains and losses. In addition, OGM application enabled also the precise definition of breakpoint sites. So we were able to identify gene disruption events, as you can see here in the photo, a translocation between chromosome 2 and 17 causing the TP53 gene disruption. And here 2 examples of RUNX1, in the first one generating a new fusion gene, RUNX1 NACA, and another translocation that was causing RUNX1 gene disruption. Regarding the regions of homozygosity, they were now more frequently found in the TRMN cohort. This coincides with the fact that regions of homozygosity tend to be associated with complex karyotypes that were enriched in the TRMN cohort. And the most recurrent regions of homozygosity were in chromosome 5, found in 4 patients, and also in chromosome 17 and 18. Regarding the alterations smaller than 5 megabases but related with affecting MDS-related genes, 66% of them were deletions affecting PTPRT, FLT3, and NF1 gene. 60% of them were insertions, to highlight one insertion in KMT2A that was causing the disruption of this gene. And regarding ETV6, we found both a deletion and an inversion that was causing the disruption of ETV6 gene. Regarding the alterations affecting other cancer-related genes, again, they were only found in the TRMN cohort, to highlight these 2 deletions, one affecting the gene XRCC5 that it's involved in the DNA damage repair mechanism, and the deletion of MBD4 gene that has been linked to cancer predisposition and leukemia. Regarding OGM, was especially efficient detecting complex genomic events of chromonagenesis. They were not very frequent, but they were found in both cohorts. Here you have 2 TRMN patients where we were able to find chromoplexy events that are 3 or more chain rearrangement between 3 or more chromosomes. And here I want to show you one young MDS case that had a complex karyotype with 4 marker chromosomes. And after the application of OGM, we were able to detect up to 3 different complex events. If we look with more detail, we had chromoplexy between chromosomes 1, 8, and 13, chromonasynthesis in chromosome 1p that are multiple gains, and chromothripsis in chromosome 21 with more than 7 gains and losses in this chromosome. Finally, the application of OGM allowed to rewrite the karyotype formula in more than 50% of patients in both cohorts, and the more frequently corrections were the loss of the 5 chromosome that was proven to be finally only 5q loss, and additional translocations not detected by karyotype. Finally, regarding those patients without mitosis, the application of OGM allowed the detection of alterations in 40% of these patients, that all of them belong to the TRMN cohort, and the remaining percentage had a normal OGM and were all from the young MDS cohort. Regarding these patients with alterations, they were TRMN and they had the relevant MDS-related alterations, such as deletion of 5q, deletion of 7q, gain of chromosome 8, deletion of 17p, and deletion of 20q. So both of them would have complex cytogenetics. Finally, in order to assess the impact of OGM findings, we try to reevaluate the IPSSR cytogenetic risk score according to OGM results. So in the TRMN cohort, the integration of OGM data allowed to reclassify 2 patients from the good risk score to the intermediate and the very poor risk score. And those patients that couldn't be classified because they didn't have a karyotype, we found that finally belonged to the poor and very poor scores. Regarding the young MDS cohort, just 1 patient was reclassified from the good to the intermediate risk score, and those patients that weren't classified finally belonged to the good score. So as conclusions, application of optical genome mapping uncovered genetic signatures that refine disease subtype classification, allowing the application of targeted therapeutic strategies, identified alterations occurring under karyotype resolution in 50% of patients with normal karyotype. It also detected critical rearrangements and identified complex genomics events of chromonagenesis. It revealed gene disruption events affecting genes included in the ISSM, as well as regions of homozygosity in 17p region. Identified recurrent deletions affecting CUX1 and PTPRT genes in the TRMN cohort, and enabled a more accurate risk stratification of patients, resulting in a switch towards prognosis cytogenetic categories and potentially altering the overall IPSSR score. So despite all of this relevant improvement, the application of OGM is bringing new questions, since we don't know yet which is the impact of some of these new alterations that are now being found by OGM. Actually, they do not belong to any of the existing scores, but for sure that they are adding more complexity to the genomic landscape of MDS and might have an impact on the prognosis of these patients. Finally, I would like to thank my team and all the physicians, lab technicians, and researchers that have collaborated with this study. And while this is an ongoing research, I'm still working with the data, so any feedback that I could receive from all of you would be really appreciated. Thank you.
Thank you for that great presentation. I think we have time maybe for one question. We're actually kind of got caught up, so that's
Beautiful
good.
work, thank you. Question, can you comment on germline-encoded copy number variants and the issue of clonal burden? In other words, you know, what is the resolution, and if you detect 5% or more cells, that how sensitive is it in terms of the size of the clone or subclone in this case?
Yes, so in terms of in terms of the size of the alteration, it's 500 base pairs. And in case of the sensitivity, it's up to 5% of the clonal size. Regarding those germline alterations, well, in that case, we have added the study of these other cancer-related genes because we were expecting that these alterations, our hypothesis is that could be linked with a germline event. And therefore, we would need to validate these alterations using a control tissue, or also our idea, or perfect idea would be for these alterations that are linked with the primary tumor, maybe to validate them at the primary tumor time in order to see if we can get more conclusions.
So, but if something is 100% clonal, then this is an issue. But if you have if you have only 5% clonal burden, then obviously it's somatic, right?
Yes. The thing also with BioNano is that, well, it's still we are still developing this technology, and we have some guidelines, but when you are working with that, we have some confidence values that can try to orientate you if you can believe this or not, because maybe, yes, it's very subclonal, and you don't know if you can believe what you're seeing. So then we are still needing other techniques such as FISH to validate them, or we are applying a lot multicolor FISH in these complex karyotypes because, yes, we have translocations with very low resolution that finally have been validated and are there by FISH, but with the scores that we get by OGM, we are not sure if we can believe them.
Got it.
Yeah.
Great.
I'd like to thank all the speakers for an excellent session, and we have a coffee break now. The next session begins at 10:50, so we have 15 minutes, so go quickly to get your coffee. And I'm sure the speakers will be happy to ask any additional questions during the coffee break, so thanks.